am Edward Nunes. I'm an addiction psychiatrist at Columbia University Medical Center. In terms of disclosures, I have no relevant financial relationships with ACGME-defined commercial interests to disclose that are relevant to this talk. The target audience. So the overarching goal of PCSS-MAT is to make available the most effective medication-assisted treatments to serve patients, primarily patients with opiate use disorders in a variety of settings, including primary care, psychiatric care, pain management settings. And so today we're going to be talking about other substance use disorders outside of opiate use disorder, which often co-occur with opiate use disorder. The educational objectives for today's presentation at the conclusion of this slideshow and talk, it's hoped that that you'll be able to diagnose and formulate a treatment plan for misuse and use disorders of other substances, including benzodiazepines, cocaine, and other stimulants like methamphetamine, and also cannabis. And we'll touch briefly on alcohol as well, although there is another whole webinar available on alcohol. So we're not going to focus primarily on alcohol. There's another full talk that covers co-occurring alcohol, which also occurs commonly in conjunction with opiate use disorder. So the outline of today's talk, again, I'm going to provide an overview of the evaluation and treatment of benzodiazepine use disorder, cocaine, methamphetamine, and prescription stimulant use disorders, and cannabis use disorder. Again, noting that there is an entire separate talk about alcohol and alcohol use disorders, although I'll touch on it a little bit here just to highlight some common themes in the evaluation and treatment across all of these different substance use disorders. So why is it important to look at comorbidity of these other substance use disorders? Well, other substance use disorders co-occur or are comorbid very commonly with opioid use disorder. The presence of one substance use disorder increases the likelihood that a patient will have other substance use disorders. The substance use disorders have common risk factors. They often go together. So among individuals with opiate use disorder, you'll often see other substance use and sometimes use disorders. Benzodiazepine use is very common. Cannabis use is very common. Cocaine use is very common. So when one substance is present, ask about other substances. Look for other substances. Ask the patient, what else are they using? Now we're going to do a little general overview of diagnosis and treatment. DSM-5 provides criteria for substance use disorders, and these are the standards in the field. And then there's some general principles of intervention that we'll go over: screening, brief intervention, and then treatment planning, including pharmacological interventions, behavioral interventions, and levels of care. And we'll talk about these in general and also with regard to each of the specific substances. So how does DSM-5 define substance use disorders? DSM-5 lists 11 criteria for symptoms. And they fall, I find it useful to think of these as falling into three broad categories: symptoms that reflect loss of control of substance use, symptoms that reflect impairment due to substance use, and symptoms that relate to physiological tolerance and withdrawal. So the loss of control symptoms include using more of the substance than the patient intended. You know, I was just going to have one drink and then I ended up having 5 or 6. I was just going to take a half a Xanax and then I ended up taking 2 or 3. Second one, tries and fails to cut down or control use. You know, I keep telling myself I'm gonna I'm going to smoke less pot, and I keep smoking 3 times a day. Every time I try to cut down, I can't seem to do it. Number 3, spends a lot of time using and recovering. Substantial amount of time spent using, spent being intoxicated, to some extent spent seeking sources of drug. And then craving. Craving's a new symptom in the criteria, but it was felt important to add because many patients with substance problems describe this. They describe, I just have a hunger for the drug. I need to get some. And they struggle with the craving. They describe it, they struggle with it. So those are the loss of control symptoms. Impairment, fairly self-explanatory, fails to meet obligations, late to work, doesn't show up to work, that sort of thing. Or it could be household obligations, family obligations. Social or interpersonal problems, relationships are damaged. Gives up important activities, stops working, stops socializing, stops engaging in hobbies that they used to engage in. The drug kind of taking over the person's life. Uses when physically hazardous, drunk driving, driving while intoxicated on other drugs. Physical or psychological problems. This patient is getting depressed or is developing stomach problems or headaches or chest pains as a result of clearly in response to using substances. So those are the impairment criteria. Then there's tolerance and withdrawal. Tolerance means the patient describes using more and more of the substance, and yet the effect, particularly the euphoric effect that the person is seeking, diminishes over time. Although tolerance develops to the other effects of a substance as well. And then withdrawal. Withdrawal are characteristic withdrawal symptoms that occur if a person's been using a drug regularly and then stops using. And each of the drug classes has distinct withdrawal syndromes, and they're each defined in separate sections of the DSM. DSM-5 also encourages clinicians to rate the severity of the substance use disorder based on how many of the symptom criteria are met. So 2 or 3 of those 11 criteria shown in the previous slide, 2 or 3 is defined as mild substance use disorder. 4 or 5 symptoms or criteria is defined as moderate, and 6 or more is defined as severe. And this is a kind of nice general rule of thumb, and it's fairly face valid and also clinically valid. And just to make the point, if a patient has only one criterion, they meet only one criterion, then technically they don't meet criteria for a substance use disorder. It's kind of an orphan, but certainly even if a patient had one of these criteria clinically, you would pay attention to it. Keep an eye on it. Wonder whether it represents a substance use disorder that's on the very mild end of the spectrum currently, but is at risk to progress. Now, what about the management, the approach to the management? First, screening. How do you ask about substance use? And the basic principle is to ask and to not feel uncomfortable about asking. So ask about use of other substances. Ask about pills. Do you try to use colloquial language? Do you take tranquilizers or downers? Do you take sleeping pills? Do you smoke pot? Do you sometimes like to take cocaine? And so forth. Just ask. And then if the patient says, yeah, I do, then you try to ascertain quantity, how much, how often, and try to ask about the DSM-5 criteria, the loss of control, the impairment, the tolerance and withdrawal. And generally, when screening for substance use disorders, it's helpful to use the principles of motivational interviewing. And I reference Miller and Rolnick's classic textbook about this. It's a whole separate topic. But just for the purposes here, motivational interviewing adheres to what's called the spirit of motivational interviewing, which is collaborative. It means that you're collaborating with the patient. You're not telling the patient what to do or kind of acting too much like the authority figure. Evocative, which means you're trying to listen as much as possible and hear the patient's point of view about things. And then support the autonomy of the patient, which means really keep the ball in the patient's court and ask open-ended questions and use reflections and try to get the patient talking. A lot more information asking the patient an open question like, tell me about your cannabis use. And let them talk about it, and then you'll hear things that tell you about impairment and loss of control, rather than rattling off a list of specific closed questions. You sometimes feel like you've tried to cut down and you can't. Blah, blah, yes, no. The open-ended question sometimes gets you a lot further. Trying to encourage the patient to open up about substance use. And if the patient, talks about the substance use disorder and acknowledges that they see it as a problem, then you try to set goals. Ask the patient to set goals. But honing to the spirit of respecting the autonomy of the patient, put the ball in the patient's court. Ask the patient, what are your goals with regard to your pot smoking? What would you like to do about it? And let the patient formulate a goal and kind of work with them with their goals. The spirit of motivational interviewing, again, collaborative, evocative, respecting the autonomy of the patient. In screening, use the tactics of motivational interviewing, which, again, the main things are open questions. Yeah, tell me about your pot smoking. What's it like? And get the patient talking and trying to get the patient to set goals. There are a number of screening instruments that are useful. The audit, for example, for alcohol. Urine toxicology, there are dipsticks available, office-based, that are quite handy. They can be administered in advance, and if the patient screens positive for benzodiazepines or cannabis or whatever, you can say, hey, looks like you've got some of this in your urine. What do you sometimes smoke? You're trying to phrase your questioning in a way that you're accepting of their use. You're not judgmental, so that it will encourage people to open up and tell you what's going on. Okay, let's move on to treatment planning. And we want to be thinking about levels of care, outpatient, intensive outpatient, inpatient, or maybe just a little bit of advice in a primary care setting and a follow-up. Behavioral treatments, pharmacological treatments, and the principle of looking for co-occurring disorders, and particularly co-occurring psychiatric disorders, which are very common in conjunction with opioid use disorder and in conjunction with cannabis, benzodiazepines, stimulant, alcohol. All of these disorders, the psychiatric disorders, commonly co-occur. And, the evidence really suggests they should be identified and treated, and that will help in the overall treatment of the patient and their substance use disorder. So what do we mean by levels of care? So we want to recommend to a patient a level of care that corresponds to the severity of their substance use disorder. So the levels could include managing a patient within a primary care or another office-based setting like a psychiatric outpatient office or clinic. Outpatient and intensive outpatient substance use treatment, where it's a clinic that really specializes in the treatment of substance use disorders. And then there are residential treatment programs or medically supervised inpatient programs. What have often gone in the past by the name of detoxification programs, although that's a term that I think is perhaps becoming somewhat outmoded. Also, dual diagnosis programs where you have patients that have combinations of severe psychiatric and substance use disorders. Now, in terms of the levels of care, there's some criteria called the ASAM criteria, the American Society of Addiction Medicine criteria. These criteria have been developed and refined over many years to help clinicians match patients with the appropriate level of care. And the ASAM criteria ask you to evaluate the patient based on 6 different dimensions of severity. So, acute intoxication or withdrawal potential, that's the first dimension. Biomedical conditions and complications, that's the second dimension. High blood pressure, heart problems, liver problems, that sort of thing. Emotional, behavioral, cognitive conditions, depression, anxiety, so forth. Readiness to change. To what extent is the patient motivated to stop using? And that really can vary widely. Dimension 5, potential for relapse and continued use. And Dimension 6, kind of closely related to Dimension 5, recovery living environment. Often the potential for relapse has a lot to do with where the patient's living and what kind of environment they're in. Are they living in a home or an apartment building or in a neighborhood where there's a lot of drug use and their dealers live there and so forth? That's really going to raise the risk for relapse. The recovery and living environment are very important. Does the patient have a stable living situation? Is it a healthy living situation? Is it a living situation that would help the patient to avoid substance use? So those are the levels of care and the ASAM criteria. Now, what about behavioral treatments? Now, we're talking about behavioral treatments that are useful generally for substance use disorders, and they include medication management, which involves clinician, physician often meeting with a patient to in a simple office visit to review how they're doing. It includes practical advice about how things are going with the substance use disorder and how to cut down or quit. There's motivational interviewing. Talked about that a little bit already. There's 12-step facilitation, which encourages and guides patients in beginning to participate in Alcohol Anonymous or Narcotics Anonymous. Those are self-help programs that can be very useful to patients. Patients often need a lot of help to get started, and that's what 12-step facilitation equips clinicians with strategies to help their patients get involved in AA or NA. There's cognitive behavioral relapse prevention, which are a set of cognitive behavioral treatments. Contingency management, which basically rewards patients for a target behavior, such as abstinence from drugs, drug-negative urines, or it can also be rewarding patients for coming to treatment sessions. There's something called network therapy, which involves getting significant others to come into the office with the patient to strategize about how the significant others can help and support the treatment plan. And then there's couples and family therapy. These are all some different strategies. Then there's pharmacological treatments, medications for detoxification, anticonvulsants or benzodiazepine tapers for alcohol or benzo or sedative use disorder, for example. Obviously, there are detoxification strategies for opiate use disorder. Alcohol use disorder, there's medication treatments including naltrexone pills or injection naltrexone, Vivitrol. There's disulfiram and acamprosate. Again, there are entire separate webinars in this series that cover alcohol. And then opiate use disorder, methadone, buprenorphine, and extended release injection. Naltrexone are the three medications with clear evidence for effectiveness. Just in terms of other substance use disorders, cannabis, cocaine, stimulants, benzodiazepines, there aren't such clearly indicated medications, although there's some that may be useful, and we'll mention them later in the talk when we talk about the specific substances. Screening for co-occurring psychiatric disorders. This is a principle that cuts across substance use problems. The co-occurring psychiatric disorders are common, and you should look for them. Mood disorders like major depression. Post-traumatic stress disorder is also very common. Stress and trauma are risk factors for the development of substance use disorders, so you'll often see these disorders go together. Other anxiety disorders, social anxiety, agoraphobia, also attention deficit hyperactivity disorder, very common. It's very useful when you're getting to know a patient with substance use disorders, ask them about their childhood school history and look for whether they appear to have had a characteristic history of attention deficit disorder, or were they ever diagnosed with attention deficit disorder? Are they still having the symptoms now as an adult? So the general principle, when there's a patient using substances too much, this may be a signal that other disorders are present. So where there's smoke, there's fire. Look, you see smoke, that's the substance use disorder. Look for the other disorders as well. Here's a case vignette just to give us a clinical scenario to think about with benzodiazepine and alcohol use. 35-year-old man with an opiate use disorder, prescription opiates progressed to heroin, has initiated office-based treatment with buprenorphine. Buprenorphine was advanced to 16 milligrams a day, and he reports ceasing opiate use. His urine toxicologies are negative for opiates, but positive for buprenorphine. So far, so good. However, his urines are intermittently positive for benzodiazepines. He also describes drinking alcohol twice a week, sometimes to intoxication. Question: what is the most important next step in his treatment? What do you think? A, increases buprenorphine dose to 24 milligrams. B, refer him to a methadone maintenance treatment program instead of the buprenorphine. C, admit to inpatient detoxification. D, start an outpatient long-acting benzodiazepine taper. Or E, obtain more history. And I would say the answer is E, obtain more history, because we don't really know that much yet about the patient. So, there's no evidence that increasing buprenorphine dose or switching to methadone maintenance would be effective in addressing the sedative or the alcohol use. You need more history to really find out what's going on and what would be the appropriate level of care. Does the patient need an inpatient detox from the alcohol, or will the patient be fine with some counseling for starters and goal setting and other things like, is there psychiatric comorbidity present? So need some more history before taking any next steps. All right, now we're going to spend some time going through the specific disorders. I'm just going to mention alcohol very quickly. Alcohol use disorder is the most common substance use disorder, along with nicotine. Prevalence in the population, according to the NESARC survey, is 30% lifetime, 8.5% within the last 12 months of the general population have an alcohol use disorder. Very common. And it's very common among patients with opiate use disorders. Apparently, approximately 30% of the patients with an opiate use disorder will have at least a lifetime history of alcohol use disorder. So it's very common, and you should look for it. Main points about alcohol. Alcohol is a sedative. It's on a broad continuum with benzodiazepines and other tranquilizers. It's been extensively studied. The risk factors include genetics and stress. There's behavioral treatments like motivational interviewing, 12-step facilitation, cognitive behavioral approaches, Alcohol will synergize with other sedatives, so the combination of alcohol and benzodiazepines is particularly dangerous, and the combination of alcohol, benzodiazepines, and opiates is especially dangerous, particularly with respect to respiratory depression. Overdose and death with opiates, which is a big public health problem now, often involves co-administration of opiates with alcohol and benzodiazepine or other tranquilizers. There are 3 FDA-approved medications: disulfiram, acamprosate, and naltrexone. So they should be thought about. And then there are a number of other meds. And again, a lot of research on alcohol that have shown some promise for treatment of alcohol use disorders. Anticonvulsants like gabapentin, carbamazepine, topiramate, varenicline, the nicotine partial agonist, and antidepressants. If there's co-occurring depression, and then buspirone if there is co-occurring anxiety disorders. So let's talk about benzodiazepines and other sedatives. Benzodiazepines are therapeutically useful medications. They're highly effective for treatment of acute anxiety and insomnia. They act at GABA receptors, and they have an inhibitory effect on neurons. They have abuse potential in vulnerable individuals. And I say in vulnerable individuals because most individuals in the general population are probably not vulnerable to developing a benzodiazepine use disorder. They don't find benzodiazepines all that reinforcing, but some individuals do. And they're the ones that are vulnerable to becoming addicted. Benzodiazepine use disorder, the prevalence is low in the general population, but it is common among patients with opiate use disorders. Again, potentially dangerous because of the risk of overdose. And again, opiate overdose deaths often involve combination of opioids with benzodiazepines. So let's talk about benzos among patients who are being treated on methadone maintenance. Here you've got a prevalence of 20 to, in some series, as high as 60% of methadone patients have got benzodiazepine use. Studies have shown that benzodiazepine use among methadone maintenance patients is associated with other drug use, it's associated with high-risk behaviors, high-risk sex, and so forth. It's associated with depression and anxiety disorders. Not uncommon for patients to seek out benzos on the street because they're struggling with a lot of anxiety, and the benzos help them feel a little better. And benzo use is associated with increased mortality among methadone patients. So it's a signal of poor prognosis and danger, should be dealt with. Why are benzos frequently comorbid with opiate use disorder? Well, they're used to self-treat anxiety and insomnia. Many patients with opiate use disorder complain of insomnia. Benzodiazepines are helpful to people to help them try to sleep. And so many patients will seek out benzos to help them sleep. Co-occurring mood and anxiety disorders, post-traumatic stress disorder. It starts as self-treatment, and then the benzodiazepine use can evolve into a use disorder where the patient starts to lose control and develop impairment from the benzodiazepine. So it's important to look for this and institute effective treatments. Truthfully, most of what we know about the treatment of benzodiazepine use disorder is by extrapolation from alcohol use disorder. But CBT, antidepressant medicines if the patient's depressed or anxious. One can extrapolate for the behavioral treatments anyway to the treatments for alcohol use disorder. There's a spectrum of benzodiazepine use from legitimate medical use to misuse to use disorders. So legitimate prescribed use is generally low dose. There's no escalation of the dose over time. Patient takes the medicine as prescribed and has a good therapeutic response. So you see a methadone patient who's seeing a psychiatrist, been diagnosed with an anxiety disorder, is taking half a milligram of Klonopin twice a day for the past 2 years, no sign of abuse. has a convincing anxiety disorder that the Klonopin helps for, that's probably a legitimate medical use. But, even if the use appears legitimate, it's important to keep an eye on it because there are non-addictive alternatives for anxiety and depressive disorders. Antidepressants for depression or anxiety disorders, sedating antidepressants like trazodone or doxepin for sleep. Okay, the next category is misuse, risky use. Misuse is defined as using the benzodiazepines not as prescribed or illicitly procured, bought on the street. Taking higher doses than prescribed. And then, of course, there's use disorder, defined as according to the DSM-5 criteria we previously went over. So what are some of the red flags for misuse or diversion? Certainly symptoms of intoxication or withdrawal. Patient comes into the office and they look slogged. They look sedated. Demands for a particular, usually fast-acting medication, like alprazolam, Xanax. The patients will say things like, Klonopin doesn't work for me. It's Xanax that works for me. Only Xanax works for me. Repeated lost prescriptions. I spilled it down the toilet or down the drain. Discordant pill counts. The patient runs out of their prescriptions early. They're excessively preoccupied with getting refills, and certainly multiple prescribers. Now that we have statewide prescription monitoring programs, it's much easier to find out if your patient is getting controlled substance prescriptions from multiple providers. So these are the red flags for misuse or diversion or use disorders. So benzodiazepine abuse potential depends in part on the pharmacokinetics. So benzodiazepines vary in how rapidly they are absorbed and also in how rapidly they are metabolized. So rapid absorption generally is associated with a rapid onset of effect, more of a euphoria or high, which is more addictive. So alprazolam and diazepam are both relatively rapidly absorbed orally, and for that reason may have more abuse or addictive potential. On the other hand, clonazepam, Klonopin, and lorazepam, Ativan, chlordiazepam epoxide, Librium, and oxazepam, Cerax, they're more slowly absorbed. And so, if you need to treat a patient with a benzodiazepine that has other substance use disorders, these slowly absorbed medicines are really the ones that are preferred to use. On the other hand, rapid absorption also equates with more rapid onset of action against anxiety. So if a patient's got a panic attack and they really need a rapid effect, then something like Xanax may serve them better. Now, what about half-life? Shorter half-life equals greater risk of withdrawal effects. So benzodiazepine withdrawal resembles alcohol withdrawal. It can include seizures and it can include delirium. And seizures you can see particularly with the more rapidly metabolized, shorter half-life medications like alprazolam and lorazepam, and possibly clonazepam. So benzodiazepine withdrawal is a serious matter. It can be severe. And of course, withdrawal also drives drug seeking. Patients go into withdrawal and they try to seek more drugs because that will pull them out of withdrawal. And alprazolam, as I'm sure many listeners have experienced, is the most popular illicit or abused benzodiazepines. Patients will often talk about benzodiazepine sticks. And those are these kind of elongated, oval-shaped blue pills, and they're 2 milligram benzodiazepine pills, and they're quite popular to sell on the street. Of course, nowadays you also have counterfeit pills selling on the street, which are quite concerning because you're not sure what's in them. Okay, benzodiazepine-like sleep medications. You got the Z drugs like Zolpidem or Ambien. They have different profile of activity at the GABA receptors, and supposedly they have less abusive potential. But the rule of thumb is that at the end of the day, from a clinical perspective, they're more similar to benzodiazepines than not. They have rapid absorption. They have pretty short half-life. You can get rebound insomnia. You can get sleepwalking and other strange nighttime side effects. You can get withdrawal effects. And so my advice is to use these Z-meds with caution in patients with opiate or other substance use disorders. And they've also been implicated in overdose deaths. So they're marketed as being less problematic, but I think one has to have a high index of suspicion that they would be equally problematic for patients and compared to the other benzodiazepines. So what about alternatives to benzodiazepines for sleep? Insomnia is a very common complaint among our opiate use disorder patients. So first of all, sleep hygiene and CBT for sleep habits. Counsel the patients about their sleep habits. This isn't a quick fix, but it can sometimes be very helpful to patients over time if they can improve their sleep habits. Treat the underlying causes of sleep disturbance, mood or anxiety disorders, opiate withdrawal, stimulant intoxication, drinking too much coffee, caffeine. Sedating antidepressants are good alternatives to tranquilizers like benzodiazepines, and they don't have abuse potential. There's trazodone, although in men you do have to beware of the rare occurrence of priapism. It's rare, but it's a very serious side effect if it occurs. Mirtazapine, Remeron, is sedating at low doses and is often quite helpful. Old-fashioned tricyclic antidepressants at low doses like doxepin and amitriptyline. Or antihistamines like Benadryl that can be bought over the counter. There's melatonin and the melatonin agonists like Romelpion, which are useful. They're more useful in signaling the body when it's time to go to sleep. So they can be helpful, most helpful, I think, in conjunction with efforts to correct a patient's sleep hygiene, to get a patient going to bed at a reasonable hour and at the same hour every night. And then more recently, there's orexin antagonists like suvorexin. So these are alternatives to benzodiazepines for sleep with really less abuse potential. It should be thought about. So evaluation of benzodiazepine use disorder. Look at the quantity and pattern of the use and the type of benzo. Is it one of the ones like Xanax that has higher abuse potential? And, evaluate the DSM-5 criteria, bearing in mind that the patients may deny excessive use or impairment. And it's certainly it's useful to obtain collateral information from reliable significant others. Is the patient observed to be intoxicated, sedated, uncoordinated? A lot of times the patients won't tell you this, but the family member will say, he's slogged. We have trouble picking him up off the floor. He's clearly out of it. And this part, why it's often very helpful to get input from the family as to what's going on. And of course, check the prescription monitoring program for prescriptions from multiple prescribers. And of course, those monitoring programs tell you exactly how much and what drug the patient's been getting. So, evaluation of benzo use. There's the urine toxicology. The thing to remember about this is that the standard immunoassays and urine tests are not so sensitive to all the benzodiazepines. So, the standard assays test for nordiazepam and oxazepam. These are the main metabolites of many benzos, including the older medications like diazepam and chloridized epoxide. But some of the newer high-potency benzodiazepines like alprazolam and clonazepam, they have different structures, different metabolic end products, and the assays are less sensitive. So just because the patient's urine is negative for benzos, they still could be using one of those more high-potency ones. You can request lower thresholds for detection or more sensitive assays if this is suspected. How do you treat benzodiazepine use disorder? The evidence on specific studies looking at treatment of benzodiazepine use disorders are limited, and so as I mentioned, a lot of what we know is kind of by extension from other substance use disorders that have been more extensively researched, like alcohol use disorder, cocaine use disorder. Advice to quit or cut down can be effective. You just say to the patient, I think you're using too much of these benzos, it's dangerous. It would be important for you to try to cut down. If you have a trusting relationship with the patient, good relationship, the patient will be open to hearing your advice. They may not go with it right away, but they'll hear you. There's motivational interviewing. CBT, there's a few studies that have looked at CBT for benzo use disorder. Evaluate for mood and anxiety disorders. Treat the mood or anxiety disorder with an SRI antidepressant, for example, if that's there, and think about the levels of care. Sometimes if you've got really severe high-use benzodiazepine use, you may need to think about a medically supervised detoxification, even on an inpatient unit. Or if the patient's really using a lot of benzos, then they may be at risk for opiate overdose. So benzodiazepine discontinuation is basically a substitution and taper strategy. Substitute a benzodiazepine with lower abuse potential and long half-life, like clonazepam, or particularly chlordiazepoxide, which has a very long half-life. Phenobarbital can also be used. Choose an equivalent starting dose, and there are tables for this to determine dose equivalencies, and taper the dose slowly over a period of weeks or even months. Oxazepam is a good choice if there's a lot of liver impairment, because oxazepam is eliminated mainly by the kidneys and through the stool. And then anticonvulsants like carbamazepine or pregabalin can be useful adjuncts in a benzodiazepine taper because they have cross tolerance. Benzodiazepine equivalency table. This is a way of determining if you have patients taking 6 or 8 milligrams of alprazolam a day, how much chlordiazepoxide do you need to start them on? You use a equivalency table like this. So here's a case vignette, again, to keep us clinically grounded. A buprenorphine patient with benzodiazepine and alcohol use. A 35-year-old man with opioid use disorder on buprenorphine 16 milligrams a day, illicit opioid abstinent, urine's intermittently positive for benzodiazepines, describes drinking alcohol twice a week. Same picture we talked about before. On further history, he's been under financial stress. Maybe he's depressed. He buys alprazolam sticks, he calls them, from his former heroin dealer. Takes half a stick at night, 1 milligram, if we can believe that what he's getting from the dealer is actually alprazolam. Sleep at night. Drinks 2 to 4 beers to relax. Acknowledges feeling high when he drinks the beers. His wife, who does not drink or take drugs and also seems reliable, says she's aware of his alprazolam use for sleep. She's worried about his alcohol use, but she has not witnessed any severe intoxication or loss of consciousness while he's drinking. He's holding down a job. He's had no lateness or absences. He wants to stop drinking, and he wants to stop buying drugs from the dealer. But he says he's tried, and he's been unable to stop either the alcohol or the alprazolam. So which medication would be the most appropriate first choice to help him stop drinking? Naltrexone, disulfiram, acamprosate, or gabapentin? What do we think? Well, I would answer disulfiram, although you could make arguments for others. I think, the disulfiram would prevent drinking if the patient takes it. If the patient drinks, they'll get sick. And if there's a significant other in the picture, it's a good strategy to have a significant other witness the daily ingestion of the disulfiram. It sounds like this patient's wife could do that. And you, of course, you need to educate the patient and the spouse about the disulfiram. Naltrexone would be contraindicated because the patients on buprenorphine, and that would precipitate withdrawal. Acamprosate has been shown to be modestly effective at reducing relapse after drinking. It's not been shown to be effective among outpatients, interestingly. Although, you could try it as a second-line treatment. It probably wouldn't do any harm. Gabapentin is not FDA approved for treatment of alcohol or benzodiazepine use disorder, but it's a good thought. It has low abuse potential. Well, there have been a few occasional reports of misuse. It may help with anxiety and sleep. There's one clinical trial, at least, that's shown that it's helpful for treatment of alcohol use disorder. I would guess the effect's probably not as powerful as the effect of disulfiram if you could get the patient to take the disulfiram, but the gabapentin's not a bad thing. So another question, what would be the most appropriate next step in managing this patient's benzodiazepine use? Alternatives: admit for inpatient benzo detoxification, prescribe alprazolam 1 milligram at bedtime with a taper schedule, prescribe clonazepam 1 milligram at bedtime and continue until the cause of the insomnia is better understood, or prescribe a low dose of doxepin, 10 or 25 milligrams, and tapering doses of clonazepam. And here, I would start with a low dose of doxepin and tapering doses of clonazepam, because you're substituting a non-addictive, possibly helpful medication to help with sleep in the form of the low-dose antidepressant doxepin, and tapering off the clonazepam tapering off the benzodiazepine using clonazepam, which is a slowly absorbed and slowly eliminated medication to try to prevent the emergence of withdrawal symptoms. Let's move on now to talk about cocaine, methamphetamine, and prescription stimulants. So cocaine and amphetamines are indirect-acting sympathomimetics. They promote the release of dopamine, norepinephrine, and serotonin from their respective neurons in the central nervous system. Cocaine works by blocking the reuptake pump on the cell surfaces. Also happens to be a local anesthetic. Amphetamines promote release of catecholamines and serotonin, partly by blocking the reuptake of these transmitters into their storage vesicles. But anyway, the net effect of both of these is that you get rapid outflow of dopamine and norepinephrine serotonin from their cells, and many patients will experience a rewarding effect or a high, and there's addictive potential stemming from this. The addictive potential seems to mainly stem from the release of dopamine in the ventral striatum or the brain reward system. So there are some milder stimulants with low abuse potential. These include the antidepressant bupropion, which acts mainly on norepinephrine, but also produces a little modest dopamine release. It's mildly energizing, but it is rarely abused, and it is a widely used effective antidepressant. And it's one of the things that one might think about in the treatment of a patient with cocaine use disorder, let's say, who's got depression and might help with the cocaine use disorder as well. There's modafinil or Provigil and armodafinil, Nuvigil. These are FDA approved for treating daytime sleepiness, sleep apnea, narcolepsy, shift work. They're mild stimulants. They're used off-label for ADHD and for chronic fatigue and for depression to some extent. Also relatively low abuse potential. How about prescription stimulants? Well, you've got dexedrine, you've got mixed, which is D-amphetamine, you've got mixed D-N-L-amphetamine, which is marketed as Adderall. You've got methylphenidate, which is more similar to cocaine. It blocks dopamine reuptake, norepinephrine reuptake. And these are effective treatments for ADHD, and they're also used as adjunctive meds in the treatment of depression. There are extended release formulations like Adderall XR and Concerta and Vyvanse, which is a prodrug of amphetamine. These have slow absorption, and thus they produce less high and they have less abuse potential. So it's the same principle as we talked about with the benzodiazepines. Look for the slow absorption medication if you need to prescribe one of these medications to a patient. Methamphetamine. Methamphetamine is a variant on amphetamine. It's readily synthesized in illicit laboratories, and it is highly prevalent in some sectors of the United States, including the West and the Midwest. It is associated with risky sex because of its sexually stimulating effects. It can be taken by mouth, but it's also smoked and injected. And there's been quite a bit of evidence about the toxicity of this drug if it's taken in large amounts over a long period of time, including neurotoxicity, perhaps more so than other stimulants. And there are multiple physical and psychological adverse effects. It's a very bad addiction. You can see severe substance use disorder stemming from methamphetamine. So what about stimulants in combination with opiate use disorder? Stimulants, cocaine commonly co-occurs with opiate use disorder, everything from casual use to speedballing, which is the combination of cocaine and opiates, to a full-out use disorder. And stimulants may also be observed among patients with opiate use disorder, like amphetamines, methamphetamine. Stimulants sometimes prescribed for ADHD. The diagnosis is not always so clearly established, so you need to get a good history and try to be convinced that the patient truly has ADHD. What are some red flags for misuse of prescribed stimulants? And this is pretty similar to what we talked about with benzodiazepines. Symptoms of intoxication or withdrawal, often helpful to get family or significant other input on this. Demands for a particular medication, usually immediate release. So the patient says, no, extended release Adderall, XR Adderall doesn't work for me, doc. I need the immediate release, 20 milligrams, please. That's all that works for me. So red flag. Repeatedly lost prescriptions, discordant pill counts, preoccupation with securing the medication supply, and of course, multiple prescribers. Evaluation of cocaine and other stimulant use disorders. Cocaine can be intranasal, intravenous, or smoked, freebased, crack. Methamphetamine may be taken by mouth or intranasal or smoked or injected. It's difficult to quantify the doses of these. Patients talk about grams or bags or different units that they sell by on the street. They query how many days per week, the route of use, intravenous being the most severe, how many hours per day using, evaluate the DSM-5 symptoms of the use disorder, ask about the dollar value of what's being consumed. That's a way to quantify use. Look for cocaine stimulant withdrawal, which consists of fatigue, depression, which may be quite severe, insomnia, then hypersomnia. You can get functional impairment for several days, even a week, from substantial stimulant cocaine withdrawal. Treatment. So there's a lot of research on behavioral treatments, motivational interviewing, contingency management, cognitive behavioral therapy, 12-step facilitation. There's evidence for the effectiveness of many of these. There's been a lot of research on medications for cocaine use disorder, although very little in the way of clear indications. Some hints that noradrenergic antidepressants like tricyclic antidepressants or bupropion may be helpful. Some studies show it, others don't. Disulfiram, topiramate, some studies show it, others don't. Cocaine use disorder, identifying ADHD seems to be a helpful treatment strategy. Dr. Levin and her colleagues at Columbia University have done a study showing that Adderall extended release is effective in helping patients stop using cocaine if they have attention deficit disorder. So look for attention deficit disorder. Amphetamine, methamphetamine use and treatment. Again, there's evidence on contingency management, cognitive behavioral therapy, 12-step facilitation. Medications, none clearly effective, FDA approved or effective, although there are hints of effectiveness from some trials, including naltrexone, bupropion, and one study with mirtazapine. So this is an ongoing effort, but naltrexone and bupropion are medications that one might think of trying. Levels of care, literally limited evidence on how to assign patients to levels of care. Most patients with cocaine or stimulant use disorder are treated as outpatients. If there's really severe psychosocial impairment, you might think about inpatient or residential treatment, really to try to enforce a period of abstinence and kind of reset things for the patient, and try to get a long-term treatment plan going that would help the patient sustain abstinence. Another case vignette, our same patient with buprenorphine and benzodiazepine and alcohol use, we talked about this patient before, doing well on the buprenorphine, but using other benzos and some alcohol. Now the patient shows up and starts to produce cocaine-positive urines. He says he takes cocaine in the morning to combat fatigue and to get to work on time. He also says his work is often tedious. Cocaine helps him stay focused. He denies all symptoms of a cocaine use disorder. He asks for a prescription of Adderall, immediate release, mentions that several years ago a doctor diagnosed him with ADHD and treated him with Adderall. His childhood history yields no indication of problems with performance or behavior at school. What do you think would be the most appropriate next step in his treatment? Institute contingency management, where cocaine-positive urines trigger reductions in his buprenorphine dose. B, prescribe Adderall, immediate release. C, prescribe Adderall, extended release. D, counsel that ongoing alprazolam and alcohol use may contribute to his fatigue. Or E, obtain collateral history from his mother about his childhood history. So I think both D and E are good answers. Counsel the patient that the ongoing alprazolam and alcohol use may be contributing to his fatigue, and if he would fix that, he might feel less need to use stimulants. And then, of course, obtain collateral history from mom about the childhood years. Did he really have ADHD? Maybe he did. He doesn't remember clearly. So I don't think you want to prescribe Adderall right away. There's not enough evidence for it. And you certainly don't want to punish the patient by reducing their opiate use disorder medication treatment, even though, there are some clinics in the United States that will discharge a patient if they don't from buprenorphine or methadone treatment if they don't stop using other drugs. I think most experts would agree now that that's a bad strategy. Okay, cannabis use and use disorder. Cannabis is interesting stuff. It contains multiple potentially active compounds, including THC, which is the cannabinoid receptor partial agonist. This is what's mainly responsible for the high. And it does that by promoting dopamine release. There's cannabidiol, which does not release dopamine, does not have abuse potential, does not bind cannabis receptors and the cannabinoid receptors in the typical way. It is a potential anticonvulsant and analgesic. There's different strains of cannabis that contain different concentrations of these different compounds. And contemporary strains may be highly potent with high concentrations of THC. You may see severe intoxication, greater risk of use disorder, and cognitive impairment and amotivational syndrome. Cannabis and opioid use disorder. Cannabis is very commonly used by patients with opiate use disorder, including people being treated with methadone or buprenorphine or naltrexone. Cannabis and THC have got shared neuropharmacological mechanisms with opiates. Cannabis withdrawal looks similar to opiate withdrawal in many respects. There's irritability, insomnia, anxiety. Cannabis seems to have analgesic properties, and patients often report taking cannabis to help them sleep. And of course, medical cannabis is now legal in many states and is being prescribed. So how do you evaluate this? How do you quantify cannabis? Patients talk about joints. They also talk about blunts. A blunt is where you cut a cigar open and fill it in with a bunch of cannabis. Rough rule of thumb, one blunt is approximately equal to 3 joints. But quantification is difficult because of variations in the potency of the cannabis. Try to elicit DSM-5 symptoms of substance use disorder. And patients often deny impairment, and again, it's useful to get collateral history from family members. There's often failure to perform in school or career, trouble with motivation. It's a clinical problem. It's tough to motivate patients that are heavy cannabis users, can be, to try to get them to acknowledge, maybe I should really try to cut down or quit. Maybe I would do better. Treatment, behavioral treatment's the mainstay. Advice to quit, motivational interviewing, CBT, contingency management, some evidence for these. Medications, various ones have been tested, none proven effective yet. Levels of care, most cannabis use can be managed on an outpatient basis. Rarely inpatient care would be needed if it's really severe use. Co-occurring opioid and other substance use disorders, conclusions. Just the main points. Co-occurring substance use is common among patients with opiate use disorder, including alcohol, benzodiazepines, cocaine, and other stimulants, and cannabis, all of which we've talked about today. Again, general principles, the first steps in evaluation. Ask the patient, use motivational interviewing principles, quantify the use, seek collateral reports from reliable significant others, and apply the DSM-5 criteria. Look for co-occurring psychiatric disorders, including depression, anxiety, PTSD, ADHD, problems with sleep and pain. Consider behavioral or pharmacological treatments for the other substance use disorders. Much of co-occurring substance use, mild, moderate, can be managed in the office or in an outpatient setting. And there are certainly indications for intensive outpatient or inpatient care, including serious risks, overdose, gross intoxication, severe psychosocial impairment, or failure to improve at lower levels of care. These are some of the references that underlie the material that I've presented today. I would just like to highlight that the PCSS program has a mentor program that is makes available to anyone who requests a mentor who is an experienced addiction clinician. The mentor program is designed to offer general information and advice to clinicians about evidence-based practices in prescribing opiate medications. You can it's a nationwide network of providers with experience treating addictions and pain, and experienced in evidence-based treatments, including medication-assisted treatments and behavioral treatments. There's a three-tiered approach that allows every mentor-mentee relationship to be catered to the specific needs, and there's no cost. It's freely provided through the PCSS program. There's also a PCSS discussion forum, which is comprised of our PCSS mentors and other experts in the field, which helps provide prompt answers to clinical questions. We also have a mentor on call each month that's available to address any submitted questions through the discussion forum, and you can create a new login account by clicking into the image on the slide and access the registration page. And this is the contact information, including the website for PCSS. And we encourage you to access these freely available resources. And that concludes the webinar for today. Thank you for your attention, and we certainly hope that it's been a helpful overview.